And what a mystery it is. The mystery of COVID has consumed so many lives around the world already, and it has shaken the foundations of many countries. And just the introduction, COVID-19 is a disease, you all know this, and we all have been going through the same information for the past year or plus. Okay, high infection rate, rapid progression, higher case fatality rate. And also the thing is initial measures taken. See, thing is all these things are familiar to us, and PPEs to reduce the inoculum and lockdowns to reduce the contact and physical barriers. Okay. And goal is to reduce the R naught and prevent the healthcare system from being overwhelmed. And we are already there. Okay? And as healthcare providers, as wonderful doctors that are dealing with this pandemic, you know, and we don't have to tell you again. And these measures work to some extent. And the goal of reducing R naught presents unique challenges, unique dichotomy, either to shut down the economy or risk illness. Okay? And real solution, and in this past year and a half, has not been forthcoming. And we all are very painfully familiar with that. Okay? And the challenge is, we cannot continually dwell on these initial measures, and need to find a real solution is at hand. Okay? Economic downturn can be disastrous, and we all know that, and the economists are already forecasting doom. This has the potential to cause a global recession, and we are there already, and job losses and all those things. Okay, then, let's concentrate on the medical aspect of this. Okay, this virus is not directly fatal. So first of all, we all need to understand that. Okay, but it is the dysfunctional immune system that is responding to unmitigated viral proliferation. That is what is causing this, causing all the complexity in dealing with this, with the disease. People are infective even while asymptomatic, and we have seen many experts go back and forth on this, and now we know, and even asymptomatic people can spread this disease. And hypoxia and hypoxemia even while with the breathing ability fully intact, and that is the problem. And it is termed as happy hypoxia, and slowly very quickly it progresses to severe dyspnea and the further complications. And cytokine storm is the characteristic climactic event, and we know now that cytokine storm happens in probably two times, and the initial one and a delayed cytokine storm. Okay, disseminated intravascular coagulation, and that is what we used to know it as, and now we know it is endothelitis, and there are several other complications that cause this coagulopathies. And the reinfection and deterioration even after testing negative, and we all are familiar with this. Many patients have been tested negative, and then they went home and celebrated, and 10 days later they lost their lives. Okay? And that is one of the biggest challenges that we are facing, and even now that is the case. Okay? And properly functioning immune system is well regulated and effectively modulated, and that is where the solution really lies. And let's see how we can unfold this. Okay? And let's go back to the immune system basics. Okay, we have two branches of immune system. Okay, this one is innate immunity and the adaptive immunity. The innate immunity, okay, let's take a look at the macrophages. And most of these cells, okay, almost all the cells in our body have this receptor called vitamin D receptor. And this vitamin D receptor, when it is, when it binds with its complement, vitamin D, good things happen. Okay, that upregulates this NF-kappa B and beta defensins and cathelicidins, and these are the compounds which are naturally antiviral, and these defensins disrupt the viral envelope. Okay? And that is how it prevents the viral, it can prevent the viral proliferation. Okay? And cathelicidins cause chemotaxis and increase in vascular permeability, and it sends out messages. So the immune system can be on guard, and and all the immune cells will be directed to the site of the infection. Okay, that is, and now we know. See, when vitamin D is present in proper quantities, okay, innate immunity works well. Innate immunity is the first line of defense, that if you will, and that is, and many people have contracted COVID, and they eventually got through it without much of any symptoms at all, and they did not even develop antibodies. And that probably because their innate immunity is working so well, this first line of defense is working so well, and that curtailed the infection right at this stage. So now we look at adaptive immunity. So now we know that innate immunity works well when when vitamin D levels are proper. Okay, adaptive immunity, you have T helper cells. Okay, and you have the naive T cells. When all these things. I don't want to go into all the details, but let's take a look at these two branches. One is Th1 branch and Th2 branch. Okay, and Th1 branch, it upregulates interferon gamma signaling, and interferon gamma signaling, it signals the macrophages to upregulate these inflammatory cytokines, IL-1, IL-2, IL-6, TNF-alpha, etc. Okay. This IL-6 is a cytokine of interest in COVID disease. Okay, that is where it is coming from. This interferon gamma signaling coming from Th1 branch, which is which causes macrophage activation, and it upregulates the production of this IL-6. Okay, and this Th1 and Th2 branches, they have to work in balance. Okay, once we lose that balance, and when most of the immune reactions, if they proceed toward Th1 branch, that is when this runaway inflammation happens because of runaway these inflammatory cytokines. Okay, and then once the patient survives this, okay, and you have B cell activation and you have antibodies. Okay, that is basically how our immune system functions. And now, okay, where does vitamin D come in this adaptive immunity? Okay, when vitamin D levels are present in proper quantities, the proper levels in the body, these Th1, all these immune reactions, they shift towards, predictably and repeatably, they shift towards Th2 branch. And that is where the upregulation of anti-inflammatory cytokines takes place, and downregulation of this inflammatory cytokines takes place. And then we can control the inflammation predictably. So we know from this slide, the takeaway is innate immunity works well if proper vitamin D levels are present, and adaptive immunity works well if proper vitamin D levels are present. Okay, so now let's go back and look at SARS and MERS. And in 2002, SARS came, and 2010, MERS came. They both are coronavirus diseases as well. And in those, and there is, the medical literature is replete with so many papers, so many publications, where if the levels of vitamin D were 60 or higher, 60 to 100 nanograms per ml, those two diseases did not affect people with vitamin D levels of 60 to 100 nanograms per ml. Okay. Now another system that is of significance here is a Renin angiotensin system. Okay, and all these things will become clear when we go further in the presentation. So you have angiotensin, and you have renin, and angiotensin 1 and ACE2 here is of significance. ACE2 will convert this angiotensin 1, which is destructive, and angiotensin 2, which are destructive, to angiotensin 1 to 9 and angiotensin 1 to 7, which are which have beneficial effects here. If you look at this, this AT1 receptor, and this, this pathway, it produces vasoconstriction, okay, and you have fibrosis, you have cell proliferation, you have inflammation, and this is thrombogenic. Okay, and if you look at the other way, and if ACE2 is working properly, and if ACE2 is present in proper quantities, what we have is the beneficial effects of vasodilation and anti-fibrotic, anti-proliferative, anti-inflammatory, anti-thrombotic, and vascular protection. So here, what we have is this virus, when it enters the cell, it uses ACE2 receptor. Okay, and ACE2 receptor, thereby it destroys the ACE2, and that is when the renin is upregulated. And when the renin is upregulated, what you have is extreme symptoms that all of you are seeing. This this extreme tachycardia, and we have seen the pulse rates, the heart rates of resting heart rates of almost 150, 160 in people where where this ACE2 is being actively destroyed. So that is one of the one of the things that we need to take a look at. Okay, and you have multi-organ injury in COVID-19. Okay, and this is a very fast-moving disease. Okay, you all know that. Okay, and patient can go from almost fully functional to almost to fatality in a matter of a week. Okay, and you have all these various systems being affected adversely as time goes by, as we just as we waste time with what is ineffective therapies. Okay, this is what we are risking. Okay, initially it is the lungs, and after that it is the kidneys, it is the liver, it is the pancreas, and pancreatitis, acute pancreatitis is one of the things that people are experiencing in routinely. And you have heart inflammation, you have microcirculation disturbances, and also this coagulation, coagulopathies. Okay, and also and it even affects the muscles. And so this and a patient, if he is not properly, if the patient is not properly taken care of, and if the inflammation is not corrected in time, what happens is they quickly proceed to multi-organ failure, and eventually dying very quickly. And now here we look at, there is a publication that was done in June of last year. Okay, and here vitamin D deficiency is less than 20 nanograms per ml, and insufficiency is 20 to 30 nanograms per ml, and normal is greater than 30 nanograms per ml. Okay, let's look at the this report. And in the deficient population, and if somebody were to contract COVID, the fatality is 98.9%. Okay, and in the insufficient group, okay, the death rate is 87.8%. 88 people out of 100 died in that group, insufficient group. Okay, and in the normal group, the fatality rate is 4.1%. This is something we all need to take note and take a look at. Okay, and now let's take a look at the disease progression. Okay, and you have this early infection, the stage 1. Okay, this is when all the government kits are being used, and all these 11 or 12 medications that are being used, okay, including the antibiotics and sometimes antivirals, and mostly anti-inflammatories like corticosteroids. This is where people start using that, and they start feeling better. In the early infection, the virus is replicating rapidly, and they have very mild infection, maybe a little bit of fever and a slight cough and sore throat, and all those things can be very easily addressed with with either Dolo or aceclofenac or diclofenac, okay? Or and with the corticosteroids. Okay, this is when and it's slowly, once the viral response phase starts coming to an end, that is when the pulmonary phase starts, and that is where the inflammatory, the host inflammatory response, the immune system is activated. Okay, this is where the real complication of COVID starts. Okay, in the pulmonary phase, okay, that is when the lungs start getting affected. It is, and also, and if patients go to the HRCT, okay, and this is where the HRCT is, they turn about CORADS 4 or CORADS 5 or 6, and the number of segments that are affected are presented as the CT score. Okay, and this is where the question that I want all of you to think about is: are we misinterpreting the CT results, and are we saying, I have seen so many patients say, we have a lot of infection in the lung. Is it infection or the inflammation? Okay, this is where the dichotomy is. If it is infection, the treatment is one way, and if it is inflammation, the treatment is totally different. Okay, and this is where we need to properly understand, okay, the pathophysiology of this disease, so we can apply the proper remedies. So in the pulmonary phase, if we do not control the inflammation, that quickly progresses to to rapid desaturation, and after that, the lung tissue will be actively, it results in active lung injury, and after that, it goes to the stage 3, and where, in the stage 2, the corticosteroids may be able to curtail the inflammation to some extent, where the inflammatory markers may come down, but quietly, what is happening is this neutrophil upregulation. Okay, and neutrophils do not respond to, they are the corticosteroids are being applied, the neutrophils are quietly going up and up and up and up. Okay, this is where stage 3 comes in. In stage 3, there is something called delayed cytokine storm. You all have seen it. If you're a hospitalist, you all have seen it. Once, the patient seems to be getting better and better and better, and then it hits from the, the cytokines from the neutrophils. They go through the roof, and the IL-6, if it was in, probably 100 or 90 range, and now in the delayed cytokine storm, it is approaching 1,000. And that is where the a patient fails rapidly, and it just goes into respiratory failure and multi-organ failure. So, we need to understand this. We need to understand this disease in the early infection stage, when the viral replication is happening rapidly. That is where, the antivirals work. And most of the antiviral therapy that we're using is in the hyperinflammation phase, in the 3rd stage, where there is no active viral replication. And that is where these antivirals, like remdesivir, are completely ineffective. Okay, so now let's look at this this slide, where this is viral. I think we already covered this in the previous slide. Okay, the current therapies in viral replication phase is antibiotics and oral steroids and antivirals like Fabiflu. Okay, one thing about Fabiflu is this, there is a lot of GI distress that can happen with Fabiflu, and most of the people who have taken this Fabiflu have, ended up with, what is it, gastrointestinal erosion, and also extreme GI distress. Okay, and also then comes the cytokine storm. The current therapies are high-dose antibiotics and high-dose IV steroids, and we are seeing almost the doses of 500 milligrams of solumedrol twice a day for days on end. Okay, and we have never seen where the steroids being used in these doses ever before. Okay? And many, because of this bilateral pneumonia. See, from viral replication to the pulmonary phase, the demarcation point is this bilateral pneumonia that starts. And in this, this is where the pneumonia, this is atypical pneumonia. This is not typical pneumonia. This is where patient needs more fluids, not less. Okay, the dehydration can kill the lungs very quickly and kill the saturations very quickly, and we have seen that because the secretions in this in COVID-19 are so thick, and people are not able to clear their lungs. Now, if they are dehydrated, how can they clear their lungs? Okay, and this is limiting fluids is one of the one of the worst things that we can do in this illness. And now we come to the hyperinflammation phase, and the treatment is high-dose antibiotics again, and high-dose IV steroids, and limit fluids, and then remdesivir and plasma is applied here. And now, because of this high-dose IV steroids, okay, the neutrophil upregulation is happening, and that causes the delayed cytokine storm, and that is the final nail in the coffin, if you will. Okay, and more of the same. We are using extremely high-dose steroids, and now dexamethasone comes into picture along with solumedrol. And here we are using IL-6 receptor antagonists, and this Actemra or tocilizumab or itolizumab. Okay, these we are using here, and the problem is, okay, these are the IL-6 receptor antagonists and IL-6 receptor antibodies. Okay, when we inject these monoclonal antibodies, we know what happens. These are the antibodies that can increase the inflammation rather than decrease the inflammation. Okay, because IL-6 is going up, and this is where we are grasping at any solution that comes our way, and giving them antibodies, IL-6 antibodies, and where the lung is already inflamed, and that causes further inflammation. And that is where we have seen people who are whose saturations on ventilators are 90s, and after IL-6 receptor antagonists were applied, and they rapidly, within an hour or so, their lung tissue got damaged, and their saturations dropped down even further. Okay, so and here. Okay, so the incubation phase, transmission phase, this is where the antivirals can be effective, and this is where the plasma therapy could be effective. Okay, but in the active phase, okay, in the pulmonary phase, it is the effectiveness of those remedies will go down rapidly. And in the hyperinflammatory phase, they are not effective at all. And in the restoration phase, the post-COVID, okay, this is where just as we have seen in the immune system basics, okay, if we do not know how to properly control that immune system, control this Th1 and Th2 branches, and if that is not modulated properly, there is no way a patient can recover. Okay, severe lung damage can happen, severe inflammation can happen at any of these three stages. Okay, and once the patient is discharged from the hospital, okay, even if they survive this high dose antibiotics and high dose steroids, and if they go to their homes, and this immune system is still active, okay, and how do we monitor that? We will look at it in the next few slides. Okay, the evidence for vitamin D. Okay, where is the evidence? Okay, and the studies have shown the treatment with high doses of 250,000 to 500,000 units of vitamin D3 to be safe in ventilated patients, and it is associated with decreased length of stay and improved recovery. Okay, this European Journal of Clinical Nutrition. Okay. Evidence that vitamin D3 could reduce risk of influenza and COVID-19 infections and deaths, nutrients, in 2020. And this is from our own doctors in Hyderabad. Okay, Dr. Maheshwar Lakireddy. Okay, he published, and him and his team, a lot of credit goes to these wonderful doctors who have done so much hard work. It says impact of daily high dose oral vitamin D therapy in the inflammatory markers in patients with COVID-19 disease. Okay, and this is published in Nature recently, and this is this is such a wonderful study, and it is such a it came out in a timely manner. Okay, now the problem here with COVID-19 and the solution problem is our immune system. Okay, if it is not functioning properly, that is the problem, and the solution, if it is modulated properly, if it is functioning properly, the solution is the immune system also. Okay, vitamin D. So let's look at vitamin D. Deficiency is implicated in several diseases. Okay, ARDS, okay, acute respiratory distress syndrome, and that is what is causing all this damage to the lungs. And most in India are deficient. Okay, up to 90%. India used to be vitamin D sufficient, and vitamin D used to be plentiful when we were an agrarian society 50, 60 years ago, when people were going out into the sun and working in the fields almost always. And now we are, we have with the technology, and people have sedentary jobs, and also particularly dark-skinned individuals. It is we need a lot more exposure to the sun. Okay, for our body to make vitamin D properly, we have to be exposed to the sun from 11 a.m. to 3 p.m. That is when the UVB rays are intense enough to produce vitamin D. And vitamin D is produced only when cholesterol levels are proper and cholesterol transport mechanisms are intact. Okay, and there is so much in our diet which completely destroys these cholesterol transport mechanisms and sulfation pathways. So I want you to think about that also. So there are multiple reasons why vitamin D levels in India are very low. The common assumption is in India gets full sun, and throughout the year people can make vitamin D, and but the problem is because of various other factors, and vitamin D levels are very low. People are not able to make enough vitamin D, and deficiency can be very easily and quickly corrected. And that work we are doing, and the work Dr. Lakireddy Maheshwar are doing has proved this point very beyond any doubt. Okay, and it is safe in single high doses or high doses over a short periods of time. And it is safe in cumulative doses up to 1 million units over a short period, or even higher doses. And because the dosing of vitamin D is dependent upon the level of immune dysfunction among the populace. Okay. In India, what we have seen over the past year is the immune dysfunction is so rampant, where in the US, we are able to get away with million units over 5 days, and people are getting well without any problem. But in India, we are having to use multiples of that number, and it is very inexpensive, and it is widely available. Okay, and we see here these are the 6+ ways where vitamin D levels proper vitamin D levels can help a COVID patient. Okay, and it can suppress the viral replication. Okay, the virus, when it enters the cell, okay, it hijacks, if you will, the cellular transcription mechanisms. Okay, these cellular transcription mechanisms are vitamin D receptor dependent. Okay, and if there is no proper levels of vitamin D, these vitamin D dependent cellular transcription mechanisms can be easily hijacked, and the viral replication can happen at orders of magnitude faster than otherwise. Okay, and this has been proven in hepatitis B. The cellular the viral replication happens orders of magnitude higher in people with low vitamin D levels. That is published evidence, that is in peer-reviewed journals. Okay, and it modulates the immune system. It modulates innate immunity. It modulates the adaptive immunity, and it can prevent common viral illnesses. Okay. Now it modulates the renin angiotensin system and prevents acute lung injury. Here I want to say a few things. Okay, you all have seen the tachycardia that is suffered by most of the COVID patients. Okay, where this heart rate is going up and up and up and up, and slowly it goes beyond 100, 110, 120, 30, 40, 50, and 160. That is the resting heart rate. These palpitations, and people are becoming restless. And we taught the patients to look at just the first number, the SpO2. As long as your SpO2 is safe, is 90, 95 plus, don't worry. And if it drops below 94, 93, 92, or 90, then come to the hospital. That is a very destructive recommendation, because there is see, in the renin angiotensin system gives a fair warning before desaturation happens, before this acute lung injury happens. This renin angiotensin system is being driven up because of the destruction of the ACE2 enzyme. Okay, this renin is upregulated, and that is what causes this, this extreme tachycardia. And guess what can modulate the renin angiotensin system? It is the vitamin D, predictably and repeatably. Okay, and then it can improve the stability of the respiratory epithelium by improving the tight junction integrity. Okay, vitamin D is just this miraculous substance which improves the tight junction integrity, and that is what tight junction integrity is extremely crucial for cellular the membrane and tissue integrity. Okay, and then it improves the endothelial stability and can prevent the sequelae leading to this disseminated intravascular coagulation and also endothelitis. So it is the same thing. It is the tight junction integrity prevents this endothelial the layer, the circulatory endothelial layer, from getting destroyed rapidly. And here, single doses of 6 lakh units or higher have been used safely. Okay, and there are so many doctors in India. Dr. Lakhireddy is one of them, and Dr. Renu Mahathani is another, and Dr. Sudha is another. And they are using these doses in autoimmune disorders with wonderful, tremendous results. Okay? And high doses, it seems to address the challenges posed by autoimmune disorders. And now we know these are all the challenges, okay, that are posed by COVID, and vitamin D seems to meet each one of them. And now, monitoring. How do we recommend patients to monitor themselves? Okay, and we need to monitor the SpO2, and that is being recommended to patients already. And but most importantly, monitor the pulse rate. A drastically elevated pulse rate almost always precedes the acute lung injury and subsequent desaturation. Okay, And there is a fair warning before the desaturation happens. If we can restore the pulse to normalcy, and that is by down-regulating the renin-angiotensin system, and that protects the lungs and preserves the saturations. No question about it, no question about it. Okay? And simple device could enable clinicians to manage patients in an ambulatory setting and prevent hospitalization. We know by the time you go to the hospital and patient is rapidly desaturating, and putting them on oxygen is not the, oxygen is not the cure for this disease. Okay. And so, if they can be, taken care of in an ambulatory setting by all of your doctors, okay, that would be the ideal situation, and that can change the trajectory of this illness in India or elsewhere in the world. Okay, now let me just quickly go through this current therapies and versus vitamin D3 and viral replication. Antivirals can be used here. Okay, that is where this is the only place where antivirals can be effective. Okay, and also the plasma, convalescent plasma, can be utilized here, where the virus is replicating at a rapid pace. This is where the patient is asymptomatic or very mildly symptomatic, and this is where patient will not be apt to spend such amounts that are required for such therapies. And is vitamin D effective here? Absolutely it is. Okay, the inflammation misinterpreted as infection. So in just CT scans, you have this CT score of 18/25 or 25/40. Okay, these are all, I have seen many clinicians refer to them as infection, and this whereas it is inflammation. Okay, high dose steroids could lead to delayed cytokine storm because of neutrophil upregulation and various other mechanisms. And here, high dose antibiotics are being used and contribute to multi-organ stress. And is vitamin D effective here? Absolutely it is. And coagulopathies. Okay, anticoagulants, they, and you all know, and many people have recovered and their lungs are fairly, they are, on oxygen supplementation, they're able to function reasonably well, they're negative and they're okay, but suddenly they suffer massive hemorrhagic stroke. Okay, and what is it due to? Okay, anticoagulants and high dose steroids, and it leads to hemorrhagic strokes and bleeding from various organs. Okay, is vitamin D effective in this stage? Absolutely. Okay, we have seen the D-dimer levels go from 8,000 to 500 or below within 1 day of vitamin D application, within 1 day. And IL-6 of triple digits go to single digits within 1 day, less than 24 hours. Okay, let's look at the cytokine storm. Okay, and for preventing cytokine storm, there is no effective therapy. Steroids can help initially, but lead to upregulation of neutrophils and causes delayed cytokine storm. And is vitamin D effective here? Absolutely it is. And endothelial damage, okay, there is no effective treatment for this. Okay, and vitamin D can improve endothelial stability, okay, and prevent endothelial damage. Epithelial damage, there is no effective treatment. Okay, vitamin D can improve the epithelial stability. Within 15 minutes of giving a bolus dose of vitamin D, you can see the saturations recover by almost 10 points. Okay, this is in the active phase of the illness. Okay, and now let's look at the RAS upregulation. Okay, renin-angiotensin system upregulation. There is no effective treatment. Okay, but vitamin D3 absolutely can address this this problem. Okay? So these are all the challenges that are posed by COVID-19 illness, and vitamin D meets each one of them. These challenges. Okay, and now management in a hospital. Okay, just a few words. We need to recognize that oxygen is not the cure. Okay, oxygen is just kicking can down the line. Okay, and we must control the inflammation. We must. Okay, and otherwise, the oxygen demand will keep on growing. It goes from 2 liters to 5 liters to 10 liters to 15 liters. And then what? Then pressurized oxygen. You have non-invasive ventilators or BiPAP machines. Okay, after then what? Okay, the inflammation is continuing, and you may have delayed cytokine storm by this time. Okay, you have intubation and then multi-organ failure. Okay, and this is not a disease that could be monitored only twice a day. or once a day, or just go home and just relax. Your heart rate is raising, going up because you're tensed up. Okay, don't just relax. That is not an advice we want to give, because there is a physiological basis for the heart rate going up. It is not because they are tensed. Okay? And patient's family must be involved in monitoring the patient constantly. Okay, so patients' families in their last days, they are being just excluded from the care. I think I think policies need to change, and patients' family must be involved, because who else can take care of these patients and monitor the patients on a regular basis, on every minute by minute basis, than their family members. Okay, even in the ICU setting, family members must be included in the care of in the care team. Okay, effective therapies must be employed early in the game. Effective therapies meaning the substances that can meet these challenges, okay, posed by COVID-19, and at all levels they need to be employed. Okay, the only thing comes to mind is vitamin D3. Okay, recognize that this is not a typical pneumonia which requires more fluid, not less. Okay, then what about vitamin D toxicity? Okay, and this is I just want to point you to this editorial that was published in Mayo Clinic. Okay, and look at this. It says vitamin D is not as toxic as was once thought. A historical perspective. It was published in May 2015. Yes, are there vitamin D toxicity studies? Absolutely, there are. Okay, and we need to recognize that there are two forms of vitamin D. One is vitamin D3, that is cholecalciferol, and vitamin D2, that is ergocalciferol. Okay, and ergocalciferol is not converted properly in the liver, and that can lead to vitamin D toxicity. And vitamin D3 is properly converted in the liver, and its pharmacodynamics are different than vitamin D2. So, and then, okay, is it possible that we misperceive the nephrotoxicity? See, the thing is, when vitamin D receptor is activated, that causes the creatinine level to go up. Okay, so this is what it says. Vitamin D receptor activation causes renin, angiotensin, aldosterone system is downregulated, and also downregulation of transforming growth factor beta, and that reduces the inflammation. That drives down the inflammation, and it drives down the mortality in chronic kidney disease patients, and it upregulates the protein and creatinine metabolism, and it reduces the renal interstitial inflammation, and it could cause renal protection. So let's not assume that this so-called this creatinine increase by increasing levels of vitamin D, that may be a protective mechanism. Let's be open to that possibility. Let's be open to that possibility, because this is the paper that was published in 2010, and which goes into excruciating detail and asks these questions, and just points to other mechanisms by which vitamin D and this receptor activation can be protective, even in chronic kidney patients, chronic kidney disease patients. I'll give you one example. Okay, we had one patient in Maharashtra, and his for the past 3 years, his creatinine levels were 19, constant, and they were not coming down. And what we did with a team of doctors, we increased his vitamin D intake almost once a day of 60,000 units for 7 days, and slowly we increased his very slowly we increased the fluid intake and he was limited to 1.2 liters. We increased it to 1.5 liters and 1.7 liters. With guess what, within 2 weeks his creatinine came down to 8. So is it this, once the vitamin D levels go up, this creatinine levels go up, are we misperceiving it as nephrotoxicity? I think this is a question that needs to be considered and needs to be answered, and especially for such a time as this. Okay, what are other vitamins and supplements that we need to take? Vitamin D3 is there, and vitamin D and magnesium, they are synergistic. They work synergistically with each other. And zinc, of course, we all know about it. And vitamin C. One thing, please do not tell patients to chew vitamin C. okay? And the vitamin C chewing, and that is ascorbic acid, and you have the combination of vitamin C, the chewing of vitamin C and corticosteroids. That is a recipe for a disaster. I have seen so many patients with just intractable thrush, okay? And they are not able to swallow. Their throat is completely inflamed, and they're not able to even swallow even water. And please let them tell your patients to swallow vitamin C, not chew vitamin C. And multivitamin are important, and multiminerals are important. Most of these, these pathways that are activated by vitamin D3, they require these minerals as cofactors in the physiological processes that happen with correction of vitamin D. Okay, let's look at some cases. Okay, we have a patient who is a 34-year-old male, tested positive, and he presents on the 7th day, and he's using medication suggested by a friend. Okay, and in most of the cases, this is what we hear. Okay, and we've been following the doctor's prescription, and where they're taking Fabiflu, they're taking Medrol, they're taking the doxycycline, they're taking azithromycin and various other things, and vitamin C. They're doing vitamin C. Okay. Here, this patient is scored at 6, and severity score on the chest CT is 12 out of 40, and his has not started desaturating yet, 97. Okay, the plan was this. Okay. We started with vitamin D3, 60,000 IU every half an hour for 5 hours, and followed by 1 hour dosing, and slowly followed by 3 hour dosing, and followed by 4 capsules per day for the next 2 or 3 days. So total 5 days, and the result is patient recovered, and he is doing well, and he did not progress from in this CT of 12 out of 40. Okay, so let's say this is about mild to moderate case where patient completely recovered. Okay, let's go with go to the next case where patient is 73-year-old male, tested positive, was vaccinated, and he was not able to eat any food as he was having pain in his throat, and he was having food in just small amounts. This is a case where the patient was probably chewing vitamin C, and that caused a lot of serious inflammation, and it inhibited his ability to consume even food, and he has vomitings and cough, severe emesis and cough. And he came to us when his saturation was 93, and his pulse rate was just slowly going up 101. And vitamin D3, 60,000 units, started with 1 hourly dosing for 3 days and reduced to 4 capsules per day for the next 2 days. And this is the progression. Okay? SpO2 reached the first day itself 95, and pulse rate of 95, and slowly, and on by the time on 6th or 7th day, the SpO2 and room air is 96, and his pulse rate is normal, and patient recovered, and he is doing well. Case 3. Okay, this is a patient, 68-year-old female, and tested positive and presents around 21st day, and severe body pains and severe myalgia, and that is that is where this myalgia is a result of uncontrolled the cytokines, IL-6 activity, okay, and fever, cough, and started. And the symptoms, on 10th May, the symptoms repeated, and medicines advised by an RMP doctor taken for 2 days, and rapid antigen test was done and indicated positive on 13th May, and CT scan was done, viral pneumonitis with 20% lung involvement. Okay, and taken to the hospital, the SpO2 level was 96, and on 15th May, the level started dropping. And 16th May, after hot water bath, SpO2 total level dropped to 84 on the same day, and she was shifted to at that time, hitherto she was not admitted to the hospital, but she was admitted on the 16th of May, and on 19th and 20th of May received remdesivir, and when the SpO2 level dropped to 80 without oxygen. On 21st May, night 11 p.m., SpO2 was 93 with oxygen and 86 without, and presented to us on 21st May. Okay, this was the plan. Arachidol 6L, 1 vial was administered mixed in milk, and given it to her. Then vitamin D, 60,000 IU, one capsule every 15 minutes for the next 5 hours. Okay, and please bear with me here, because do not just jump to any conclusions here with respect to this dosing. Okay, followed by 2 capsules every hour, followed by 1 capsule every 3 hours, and then 1 capsule every 4 hours, and the oxygen levels were stable. Patient was given vitamin D3 in 2000 IU. So we see, the thing is, the goal is to stabilize the patient. They're giving enough doses to stabilize the patient and slowly bring it down, bring down the vitamin D input to 2000 IU on a timely basis until discharge. Because in the constant input of vitamin D is essential, so that the immune reactions can be trained, immune system can be trained, because the immune system has been dysfunctional for so long. It needs to be slowly trained in baby steps. SpO2 88 without oxygen support, and 95 without O2, that is day 1. Okay, and pulse rate, day 1 of vitamin D therapy, pulse rate between 77 and 88. Okay, and this is not active illness. Pulse rate is calm, means this is not active illness. And day 4, SpO2 90 without O2 support, and day 5, 92, and day 6, 93, and day of discharge. Okay, SpO2 without oxygen support is 96 and 97, pulse rate normal, patient recovered and discharged. Okay. Case 4. Okay, these are all the cases from the hospitals where patients were failing and they recovered. And 45-year-old male tested positive and presents on the 5th day, and he had breathing problem and severe cough. Okay, and presenting this is the SpO2 of 85 and pulse rate of 105 and 30 to 40% lung inflammation. I don't want to call it infection, inflammation, and taken to the hospital by the family. Even after hospitalization, cough did not subside. He was put on oxygen support, restarted vitamin D doses in the hospital. And vitamin D3 plan was this: vitamin D3 60,000 IU every half hour for 1 day, followed by 1 hour dosing, followed by 2 hour dosing, followed by 3 hours, and then 4 hours, and maintenance of 4 capsules per day. And his oxygen levels gradually increased without O2 support, and he was discharged on oxygen concentrator. Patient recovered and doing well, SpO2 above 96 and normal on the day of discharge. Okay. And case 5, a 46-year-old male, not tested positive, but has all symptoms detected. Symptoms: high fever, severe cough, SpO2 of 96, and pulse rate varying from 90 to 120. This is where the active illness is starting, and patient's oxygen levels fell down to 83. Arachital 6L was given, his oxygen levels came to 95. Okay, but the problem is, once they come to 95, they need to be maintained there. Okay, and he refused taking vitamin D, as suggested. Later, he became weak and refused D3, and his oxygen levels went down to 65 within 4 hours, and patient passed away. Okay, case 6, 26-year-old 6-month pregnant female, tested positive. Symptoms: extreme tachycardia, palpitations, falling saturations, and cough. Okay, and when she was presented, SpO2 was 94 and pulse rate of 144 or 145. Okay, and plan was D3 bolus of 6 capsules, 3 times 60K IU, followed by 1 capsule every 15 minutes for 1 hour, and upon which the pulse rate came down to 110 and the saturation went up to 96, 97. Okay, and they were not consistent with D3 dosing, and pulse increased again by next morning to 145 and saturation fell below 90, and started the regimen again, and saturations recovered above 90 and pulse rate less than 120. And patient's parents took her to the hospital, and there was a gap. This gap during the active phase of illness is very deadly. Gap in D3 administration, SpO2 by the time she reached the hospital fell to mid 70s, and patient spent around 13 days in the hospital, and no D3 was given. And on the 17th day, they tried to save mom by extracting the baby. Baby did not survive, and the next day the mother died, and patient passed away. So the case 7, Okay, he's a 25-year-old male, not tested, but suddenly developed palpitations and severe tachycardia, and tachycardia and palpitations, and that's it. Those were the symptoms, and his SpO2 was 98, and this is where this active, this illness is starting. This is the threshold where, and his pulse rate was 155. Okay, a D3 bolus of Arachital 6L followed by 1 capsule every 15 minutes for 1 hour, then 30 minutes dosing and for 2 hours, and then we went to split doses. Okay, we split about 5 or 6 capsules in about 10 spoons of ghee, and you administer a quarter teaspoon every 15 minutes. Okay, pulse rate came down to 120 beats per minute, and patient was very consistent in taking D3. PR pulse rate was still high, BP normal, and gave 1 tablet of ivermectin twice a day. By second day, went to 2-hourly dose, and pulse rate was completely normal, about in mid-70s, and SpO2 of greater than 97. Problem is, patient thought he was well, and he stopped D3 on second day, thinking that he completely recovered. Third day, pulse rate started going up again. On the fourth day, it was greater than 135, and SpO2 came to 95. Okay? And patient was started on split doses again and of D3, and he's recovered. Okay, and doing well. SpO2 currently 98 or greater, and his pulse rate is normal. And case 8, patient 45-year-old male, positive, waited till severe shortness of breath developed, and chest tightness, severe cough, extreme dyspnea. Okay. SpO2 of 96 and falling, and pulse rate of 80, and patient started on D3, started recovering, but upon conflicting advice, I stopped D3, and for 7 hours, and symptoms worsened. SpO2 fell below 90, and pulse rate increased to greater than 100. Okay, the plan was this: bolus of Arachital 6L followed by 1 capsule every 15 minutes for 1 hour, and once they are stable at that dose, go to 30-minute dosing for 2 hours and then split doses. We had to restart this during the first 3 days several times because they were not consistent. Okay, once these immune reactions, they are curtailed and they start picking up again, this need to be revisited. And patient saturations fell to less than 90 and started sliding close to 80, and patient supplemented with O2 concentrator and maintained above 92 with that. And on 9/24/2020, IL-6 was 94.6 picograms per ml, and on 9/26, okay, that is September 26th. I'm sorry about this US convention of dating. Okay. 2 days after starting D3, IL-6 was 6.93 picograms per ml, which is normal within limits, and patient's IL-6 did not go up beyond this at all. Over next 7 days, patient was put on tapering split doses of D3 and recovered to SpO2 of greater than 96 and pulse rate normal. Patient has recovered and doing extremely well. Okay. The case 9 is this: patient is a 32-year-old male, positive, waited till severe shortness of breath developed, and chest tightness, severe cough, and extreme dyspnea. SpO2 by the time he was admitted to the hospital was 65 and falling, and pulse rate was around 100. Patient admitted to the hospital and came to us with saturations of around 75 to 80 on oxygen support, and CT severity score was 18 out of 25. Okay, on 428. He's a 32-year-old male, and with this CT score and with those saturations, there is very little hope that anybody can do. D3 intake from 429, that is April 29th to May 8th, about 10 days with aggressive doses, and we suggested the dose, and we were and his brother was taking care of the patient, and he was given aggressive doses, and acetylcysteine 600 milligrams was given every 2 hours during waking hours, and nebulization with Budecort and normal saline, and about 2 ml of normal saline, about 2 to 3 drops of hydrogen peroxide 3%, and 2 to 3 drops of butadiene was given on an hourly basis to control the cough. And that is the only normal saline, hydrogen peroxide, and butadiene. That is very effective in controlling the cough. Okay? And here, The patient's lungs were compromised to a point where the saturations were not, just improving of oxygen. So we started him on, and we stopped after 10 days. We stopped vitamin D completely and started giving him egg yolks. What do egg yolks contain? Egg yolks contain lecithin, and they contain phospholipids, which are essential for the surfactant production. And surfactant is that is the one which can repair the lungs and the alveolar membrane very quickly. And he was given 12 egg yolks per day very promptly, and breathing exercises 10 to 15 minutes every hour, and lemon water with rock salt. One thing that is very common in COVID patients is electrolyte imbalances, and also buttermilk with rock salt was given about 4 times a day. Here, he was consuming water about 5 liters per day. Okay? And now, here, an oxygen supply of 15 liters, his saturation slowly improved from 88 and 65. It was 65 without support. Every day, and they improved throughout all this treatment by a point or two till the saturations reached 99% on June 1st. And patient discharged on June 1st after complete recovery. And patient was cared for by his younger brother every moment. He was by his side, and he was there. And if anything, if there is any problem, he was there taking care of him. Okay, and patient is doing well, and his creatinine is normal in spite of extremely high doses of vitamin D, even after 2 months, even after a month, about 5 weeks. And he has mild hypercalcemia, which is being treated. And okay, let's talk about hypervitaminosis just briefly. And few patients who required very high doses developed symptoms of hypervitaminosis. Okay, hypercalcemia, about 13 to 17 milligrams per deciliter, and elevated creatinine, 1.3 to 5.1 mg per dl, and electrolyte imbalances. These people were started on IV fluids and sodium bicarbonate and calcitonin nasal spray for 2 days, and some on zoledronic acid IV. And electrolyte correction was done, and they suffered from severe constipation, for which lactulose and Dulcolax was used, and saline enemas were used. And they have hypertension, for which ARBs were used, and calcium channel blockers and nitrates were used. And patient saturation, all these patients, their saturation recovered. Okay, they were presented with complete, almost at the verge of failure, and lungs were protected. And now what we need to look at is this calcitriol, the active form of vitamin D. The half-life is 15 hours, and calcifidiol, that is 25 hydroxy vitamin D, that is the first metabolite of vitamin cholecalciferol. The half-life is 15 days. What does that mean? Okay, even if we push these vitamin D levels beyond a toxic level, like 300, 400, okay, within 15 days that is cut down by half. Okay, and another 15 days, another 2 more weeks. So by 4 weeks, it comes to 1 quarter. Okay, so within a month, or month to 6 weeks, their levels are normal. Within 4 to 6 weeks, excess will be eliminated. Almost all had their levels below toxic level, after 6 weeks. Okay, and vitamin D receptor activation, though may cause elevated creatinine in the short term, may be protective to the renal function, as we have seen by the 2010 publication. And we can manage vitamin D toxicity occurring in a very few individuals and reduce the serum calcium very easily within a matter of 2 or 3 days. Okay? And creatinine would become normal, while vitamin D level reaches normal levels in 4 to 6 weeks. So this is what we are facing. So we have an option, whether to lose the lungs completely, or just protect the lungs and preserve life and deal with hypervitaminosis in these patients, which we can do, which all of you are familiar with, treating hypervitaminosis. This only happened in probably less than 1% of the patients. And I'd like to acknowledge my sincere gratitude to the member of Corona Rescue team, and a team of doctors and medical professionals, and everyone. And all these cases, some of these cases were recovered under their guidance. And these are the people who have recovered from COVID themselves and now helping others. And they are working tirelessly with patients that are failing, and bringing many from the brink of death. I would like to say a word of appreciation and word of thanks to Dr. Maheshwar Lakiredi of Nizam Institute for his tireless work for the past few years in vitamin D space. And he is one of the few vitamin D doctors, along with Dr. Renu Mahatani and Dr. Sudha Chepiala and a few other doctors. And Dr. Maheshwar, thank you so much. My sincere gratitude to you, sir.